Professor.
I think your mic's off.
Oh, I apologize. All right, let me start from the beginning. Okay, so in answer to the question earlier, Mongolism, the physical features of Mongolism are, if you see someone with Down syndrome, that's the example of Mongolism, okay? So moving on to lymphocytic leukemia. Okay, lymphoproliferative disorders are clonal proliferations of maturing B or T lymphocytes. And the difference between leukemia and lymphoma is that leukemias affect the bone marrow and lymphomas infect the lymph nodes. Okay, so if you get proliferation of immature lymphocytes and it originates in the bone marrow, it's a leukemia. And then if it affects the lymph nodes, then it's called a lymphoma. Okay. Phases, chronic lymphoid leukemias may proceed in phases, just like in CML. You got your chronic, and then it'll progress to the more serious acute phase. Here in CLL, chronic lymphocytic leukemia, you have your early phase and your transformation phase, starting with small cells are small in size, and it transform into the larger immature cells. The most common type of leukemia in older adults is CLL, not CML. So CLL is the most common type of leukemia in older adults. So if an elderly has leukemia, chances are it's going to be CLL, not so much CML. The most frequently a neoplasm of B lymphocytes, and that's what CLL is, and that's what the BCLL is. So CLL is most frequently a neoplasm of the B lymphocytes. Proliferation of the T lymphocytes is less common, but just keep in mind that CLL it's most frequently a neoplasm of the B lymphocytes. Okay. CLL may show the following: increased prolymphocytes. Prolymphocytes is the middle stage in maturation. It goes blast, prolymphocytes, then lymphocytes. It's pretty easy. Increase in prolymphocytes greater than 10%, exaggerated nuclear irregularities, proliferating lymphocytes, often larger than 2 red blood cells, and deep nuclear folds such as Reiter cells. And I'll show you what a Reiter cell is. It's kind of like a clover leaf. So if you see a clover leaf looking nucleus, it's probably some type of chronic lymphocytic leukemia. I know these look like monocytes. To me, they look like monocytes, but they're actually lymphocytes. Okay. This is the Reiter cell. If you look at the nucleus here and look at the cloverleaf here, this is called a Reiter cell. And this is actually this cleft here, that's actually called a butt cell. Okay. And these are two types of abnormal lymphocytes. You see a field like this, okay, you can see that they're mature because of the channeling of the cracked mosaic appearance of the chromatin. See how, as opposed to it being fine chromatin, these are mature. Remember, the more dark and you see channeling and the coarse clumpness, coarse clumped nucleus, like here, it's coarse and clumped. That these are mature, okay, it's pretty dark, as opposed to fine granular. These are mature lymphocytes. And also too, looking at this field, if you see a field like this, that this tells you that there's a high, you normally don't see this many white blood cells in a field like this. So this patient has a high white count. So this is probably CLL. Again, it's the most common leukemia in elderly adults. Again, more lymphocytes. I don't see any other cells in another cell line. I don't see any neutrophils. I don't see any monocytes. So this is probably a chronic lymphocytic leukemia. So if you see mainly lymphocytes and it's a high white count, it's probably going to be CLL. CLL, the DNA of B cell is damaged. Remember, it's proliferation of the B cells. And again, because these are cancer cells, you can't fight infection. These are not normal cells. Normally, the B lymphocytes will turn into plasma cells and you make antibodies. These cells are leukemia cells or cancer cells. They're sick, so they won't be able to help you fight infection. Okay. Altered immunity can lead to the production of autoantibodies. So you have altered immunity here, obviously, because you're not going to be producing antibodies, because B cells produce plasma cells, which produces antibodies, if you can remember that. But altered immunity can lead to the production of autoantibodies, and that's not supposed to happen. These cells grow out of control and accumulate in the bone marrow and the blood, where they crowd out the healthy blood cells. And that's the hallmark characteristic of a leukemia cell. It displaces or it crowds out the healthy blood cells, okay? CLL is now felt to be identical to a disease called small lymphocytic leukemia, SLL, and it's a type of non-Hodgkin's lymphoma. So I'll be talking about the non-Hodgkin's lymphoma in a separate lecture. And this one presents primarily in the lymph nodes. As you recall, I just mentioned, if it affects the lymph nodes, then it's a lymphoma. Accumulating lymphocyte mass leads to neutropenia, which is low neutrophil count, anemia, and thrombocytopenia, low platelet count. CLL, like I mentioned earlier, is a disease of adults, and it's rare in cases, and rarely it occurs in teenagers and occasionally in children, but mainly CLL is found in elderly adults. Most or greater than 75% of people newly diagnosed with CLL over the age of 50, and the majority are men. Okay. Again, similar to CML, most people are diagnosed without symptoms. So you don't feel good, you go to the doctor, he'll order some lab tests, chemistries, and a CBC, and he'll come back. He'll says, unfortunately, sir, it looks like you have leukemia. We'll have to do further tests. Okay, so identification comes as a result of a routine blood test that returns a high white blood cell count. CLL progresses, and the symptoms include swollen lymph nodes, spleen and liver, anemia, and infections. Okay, again, you're prone to infections. You have a high white count, but it doesn't. It's not going to help you. First suspicion of CLL is an elevated lymph count, lymphocytosis. Okay, this is frequently, like I mentioned earlier, is an incidental finding on routine physician visit. Most often, the lymphocyte count is greater than 4,000 cells, and that's through flow cytometry. Okay, so the presence of elevated lymph count should make you suspicious that you have CLL, but don't say just because you have a lot of lymphocytes you think it's CLL. Just make sure that you tell the pathologist that it's suggestive of CLL. The confirmatory test will be flow cytometry, and flow cytometry takes a look at the surface markers on the lymphocytes. And flow cytometry, don't get into that technology that much, but specific antibodies to markers, like I said, on the surface of the lymphocytes, molecules with fluorescent tags. And because it's CLL, they're going to be looking at the lymphocytes of the B cell lineage. Remember, CLL is with the B cells. One physical characteristic of patients with CLL, because it's an elevated lymphocyte count, is one thing that you'll see is when you make the smears, these lymphocytes are pretty fragile. And as it turns out, when you make the smear, you come up with what's called smudge cells. So this is a smudge cell. This can also be called like a basket cell. So because the lymphocytes are so fragile, when you make a smear, it actually distorts or destroys the lymphocyte. This used to be a lymphocyte, and you'll get this smudge cell, or it's called a basket cell. So when you see this, it's not diagnostic, but it's like it's also a finding that's associated with CLL, but Just because you report out 1 or 2 smudge cells, don't label the patient as having CLL. You gotta let the pathologist do that. But smudge cells are reportable, but and it's only suggestive of CLL, but it's not at the CLS level. It's not a diagnosis. You can't really diagnose based on smudge cell. You have to do the flow cytometry and do the cell surface markers. Okay, but in CLL, if you see smudge cells, you may see smudge cells because of the fragile nature of the lymphocytes. Other types of hematologic disorders that look like CLL are mantle cell lymphoma, marginal cell lymphoma, B-cell prolymphocytic leukemia, lymphoplasmacytic lymphoma. Okay, B-cell prolymphocytic leukemia. Again, so prolymphocytes. You can see these are lymphocytic, but also too, these are not normal. Here you see a lot of folding. It's an early stage lymphocyte, but there's folding. There's nucleoli making it an early stage. You also see nucleoli here too, but you also see folding, and it's not supposed to be like that. It's supposed to be nice and smooth. You see a little cleft here and a cleft there and a cleft here. So these are not normal cells. They're not normal cells. So this was labeled as a prolymphocytic. So it's a little bit older than the blast stage, a little bit older than the blast stage, but not mature. So that puts it in the prolymphocytic category. So the stages of maturation for lymphocytes is blast or lymphoblast, next is prolymphocyte, and then you have the mature lymphocyte. So here, this is another type of leukemia. This is hairy cell leukemia. Hairy cell leukemia. So, and the reason why it's called hairy cell leukemia is because the cytoplasm kind of looks a little hairy, like it's not really smooth and circular. One way to diagnose that hairy cell leukemia is present is to do a stain that's called tartrate resistant acid phosphatase. It's called a trap stain. Let me see. Tartrate resistant acid phosphatase. I'm gonna type that out for you because I think you need to know. Well, I'll type it out to you later. If I open up that Word document, it's going to show you the quiz, and I don't want to do that. But tartrate resistant acid phosphatase, or TRAP, TRAP, is a special stain that will diagnose hairy cell leukemia. Hairy cell leukemia TRAP stain. It's called a TRAP stain, TRAP, tartrate resistant acid phosphatase. Okay, so that is a stain that will help you identify hairy cell leukemia. While generally considered incurable, CLL progresses slowly in most cases. Many people with CLL lead normal and active lives. So you can live for a long time into your 80s and 90s and still have CLL. Even though it's not curable, you can have CLL, live a normal life. Because it's slow onset, early stage CLL is generally not treated. And treatment, if you do decide to treat, then what you need to do is consider the quality of life. So early CLL intervention does not necessarily improve survival time. So you can treat CLL, but that doesn't necessarily mean it's going to make you live longer. Okay, so the treatment may or may not work. The decision to treat or start CLL treatment, like I said, you need to consider the patient's quality of life, because a lot of times people will say it's not the leukemia that's going to kill you, it's the medication. Okay, so significant thing, an important thing to consider is your quality of life when you undergo treatment. There's no survival advantage to treating the disease. So like I said, treatment may or may not help.
Professor Magic, how does quality of life actually change for you? Like, what do you when you say that? What do you mean by that? Like, you can't walk
Well,
anymore, or
no, not necessarily. I mean, if you go undergo chemotherapy, that can make you tired. It can have side effects. That's what I mean. It's going to affect you. You're going to have side effects. It's going to make you sick. I know people who've undergone chemotherapy, and they just hated it, because it made them really sick, it made them tired. That's what I mean by quality of life. So, and it's the medication that did that to them. Otherwise, if you don't treat it, then you can still continue on living your normal routine, your normal life, and still have CLL. Like I said, undergoing treatment may or may not help. It's not going to make you live. It may or may not help you live longer. So that's why you have to consider your quality of life. People, you may believe that if you undergo therapy or the chemotherapy or even the radiation therapy, then they have side effects. Those therapies have side effects to it. Okay, that can make you tired, make you sick, just make you not feel good. That's what I mean by quality of life. Does that answer your question, Rudy?
yes, thank you, yes.
Okay. All right. For therapy, usually it's a combination therapy. Options are effective, usually purine analogs like fludarabine and with an alkylating agent like cyclophosphamide. And when you have combination therapies like this, you get a higher response rate and a longer progression survival time than single agent. So usually a combination of the drug. So you can have fludarabine with cyclophosphamide, or fludarabine with rituximab, or fludarabine with cyclophosphamide and rituximide. So those are the fludarabine combinations. Or you can have what's called CHOP, which is cyclophosphamide, doxorubicin, vincristine, and prednisolone. Okay, so those are the types of therapies, but basically the bottom line is that they're combinations of drugs. Another way to treat it is a allogeneic bone marrow stem cell transplant. Allo meaning, as you remember, allo meaning from somebody else, a donor. Bone marrow transplant, and usually it's used as a first-line treatment for CLL due to its risk. And usually when you do a bone marrow transplant, the older you are, the success rate diminishes. So the younger you are, then you have a better success rate. Okay, so this is an increasing interest in the use of reduced intensity allogeneic stem cell transplantation, and it offers a prospect of cure for selected patients with a suitable donor. So, and the benefit is survival can vary from 5 years to more than 25 years. But again, it's not really guaranteed. You can predict the survival length by looking at the DNA mutations. So that's at the molecular level. And if your disease progresses slowly, then you may or may not need treatment. So like I said, if it's a slow progressing disease, then you may make it worse. Again, consider the quality of life if you decide to take medication, chemotherapy, or radiation therapy, or whatever kind of treatment you're going to receive. Oh, and that's it for chronic lymphocytic leukemia. Are there any questions?
I had one question. What's neoplasm?
Neoplasm is like a cancer cell. A neoplasm is starting to become a plant cancer cell. Neoplastic. So it's new. Remember, plastic from plasia production. So neoplasms generally are not good. It's starting to become a cancer cell.
Okay, thank you.
You're welcome. Anybody else? Okay. So now so tomorrow you're not going to be bombarded like you were last last week. You're only going to get 2 quizzes tomorrow. So let me stop sharing my screen. And then we'll do some review. All right. So tomorrow, you're going to be getting from the lymphocyte lecture. Okay, so you got your T lymphocytes and your B T cells and B cells. Which of the two produces antibodies? Anybody?
B cells.
B cells? Are you sure? And where do the antibodies come from actually? What exactly is the cell that it comes from?
Plasma cell.
Plasma cells. Yeah, that's too easy. All right, make sure you know what a definition of interferon is. Now, you don't need to know the different types of interferon like IF, whatever. But what are interferons by definition? Make sure you know that. The CD8 cells, those are the cells, they act like the T lymphocytes. What are they looking for? Remember, I talked about the antigen presenting cells and the fragments of antigen presenting antigenic material for certain cells to come down and swoop on it. So these cells are the cells that look for those antigenic material, antigen fragments. Like, for example, if a respiratory cell is infected with a virus, then that respiratory cell is actually going to expose that virus and present it on the surface of the cells. Certain cells come down and swoop on it, and not macrophages. Macrophages can do that, but a certain cell will come down and take care of it. Okay, make sure you know what dendritic cells are and antigen presenting cells. Those are actually two terms that are synonymous. Just like interferon, make sure you know what an interleukin is and make sure you know what cytokines do. Make sure you know what cytokines do. Make sure you know the function of cytokines, and that was from your homework. I also corrected your homework, and I'll get you those back to you after this lecture. No, make sure you know what the process for, the process for when cells go between the endothelial cells. It takes a shortcut. What is that called? Does anybody remember what that's called?
Diapedesis.
Say again.
Diapedesis.
Diapedesis. Okay. True or false? Can lymphocytes contain granules, even though they're not formally called granulocytes? Can they contain granules?
Yes.
Yes. Why yes?
I remember seeing it in one of the images where it looked like it had some granules in there.
Well, it's not illegal for lymphocytes to have granules, but what's a situation where lymphocytes need to have granules?
For like cytotoxicity or
Say that one more time.
to kill the infected cells,
Uh-huh.
right?
And what cell is that? It's
Is it the
called
T? T cell?
cytotoxic T lymphocyte. The CTL, cytotoxic T lymphocyte. All right. Yeah, those cells have granules. They have to have digestive granules. And you know the function of the B cells, the type of immunity, and the type of a T cell, and the type of immunity of a B cell, correct?
Yes.
It's pretty basic. All right, now for Monocytes and macrophages. What did you guys think about that exercise? Monocytes versus macrophages. Now, having the review, it's easy to do, and as a homework assignment, it should have been a piece of cake. But if you didn't have the review, would you be able to identify a lymphocyte versus a monocyte?
I can probably get a passing grade on that.
That's not the answer I was hoping for. But you know, if you think about it, if you go over the review and you look at the features of, okay, so for me, a lot of times when you typically when you identify a cell, you look at the nucleus right off the bat. But for me, for the monocyte, I look at the cytoplasm and I look for that distinctive gray color. If it has that distinctive gray color, dull gray color, it's probably a monocyte. And then I'll look at the cytoplasm. So that's what I do when I identify a monocyte. Because versus a lymphocyte, a monocyte's going to have a different shape, like a sausage shape, a horseshoe shape, or it's going to have folding. A lymphocyte has a circular, round, rigid, or even if it's not circular, it's darker and it doesn't look spongy looking, but it looks rigid looking. And a cytoplasm of a lymphocyte can have bluish tinge and it's clear. But if you look at the dull gray blue cytoplasm, and make sure you look at the characteristics in the PowerPoint presentation, there's distinctive features to look at. So the cytoplasm is dull gray blue. Once you see that, and once you see a monocyte, memorize that color. And that will be a monocyte forever for you. If you see a clear cytoplasm, but with bluish tinge, then chances are it's a lymphocyte. And then also too, lymphocytes are generally roundish in appearance and it's darker and it's more rigid looking. A monocyte, even though they're not always horseshoe or kidney bean shaped, it has a lot of folding and it's spongy looking. The nucleus of a monocyte is softer, so it's kind of like a sponge. You know how you can twist the sponge and it takes on different shape? You can't really do that with a lymphocyte. Okay, so if you think about those features, you know, and for exam purposes, you need to be able to list those features. Okay, so lymphocyte versus monocyte should be easy for you if you go over it a few more times. But look at, I'll be returning the homework to you, but look, you know, go through the PowerPoint, go through the review that I gave you, lymphocyte versus monocyte, and ask yourself, why did I call this a monocyte, or why did I call this a lymphocyte? Look at the cytoplasm and look at the nucleus. Okay, so I'll probably give you a quiz, lymphocyte versus monocyte, and you won't have the answer key. The mononuclear phagocyte system consists of certain cells. Make sure you know that. Okay, in the maturation sequence of a monocyte, there's only 3 stages of the monocytic series. Actually, there's 4. You got your monoblast, your promonocyte, and then your monocyte, right? But it doesn't end there, because after the monocyte stage, if you recall, it only stays at the monocyte stage for a little bit, and then you know what it becomes, right? What does it become? After monocyte. Okay, let's see, Jaslyn, and what does it become after a monocyte? What cell is after the monocyte stage? Madeline? What's the stage after monocyte? Okay, Jeremy, what is it?
Is it macrophage?
Yeah, it's a macrophage or histiocyte. Okay, make sure you know the characteristics of the blast, promonocyte, and the monocyte. Know what a macrophage looks like, or a histiocyte. They're two of the same thing. the descriptive features of a monocyte. Okay, I went over that, of the cytoplasm and the chromatin. Make sure you know the characteristic appearances of both the cytoplasm and the nucleus of a monocyte. Know the function of the vacuoles in a monocyte. And like I said, know the descriptive features of the monocytes. And macrophages are previously monocytes. Where are macrophages found? Make sure you know where that is. And in the laboratory, chances are you won't see a macrophage on the peripheral smear, but what type of specimen is best to identify a macrophage? All right. Okay, so that's it for the review, no exam review. So next week, you are going to be getting exam 3. So it's going to be the same format. It's going to be multiple choice. You always have multiple choice. There's going to be matching, and I think I'm going to have pictures. All right. I'm going to have pictures. So, and I'll send you by email the review for exam 3. Are there any questions? Okay. So what I'll do is I'll be sending you your homework. I'll be sending you exam 2 and the quizzes, and I'll also be sending you what your current grade is. All right. If you don't have any more questions, then I will see you next Wednesday. All right.
Okay.
All right. Thank you. Have a
Good night.
Have a good night.
Have a good evening. Thank you. You too.